Hey guys, good morning. I'm going to try to do a review for you guys over chapter 14, 16, 19. That's really all I know to do. I can't post every lecture on here. They're very large. We have to put them over onto YouTube, and so it takes a little time. If you hear any noise, that's probably our dog Louie. He'll probably start snoring here in a little bit. But I'm going to try to be quick through this, but it should narrow it down like we usually do, and hopefully you guys are doing that, and hopefully you like the format we're doing it. You're kind of having to learn on your own, but hopefully you're not standing or sitting behind a computer all day long. So what I want you to do is get out and do something, and then study when you want to. So hopefully you like that. But I'll keep doing the reviews. One more thing, the last lab exam, we're probably going to have to do it the same format. I'll try not to screw it up like I did last time. I chose one little thing wrong, and when I was choosing the conditions of the test, and I'll fix that for next time, so it should be more normal. All right, let's get started. Okay, chapter 14 is about the blood, and my wife's going to blow the picture up so you can see it well. But I may be pointing at the screen here and there. We talked about blood being a connective tissue back in chapter 5. I don't want to start lecturing here, but basically what this chapter is going to do is go through each blood cell and the function. Short and sweet. There's not much more than that. So I'm going to go ahead and pan forward here. If we centrifuge blood, it will break down into 3 layers actually. Plasma, which is the liquid portion, is 55%. I want you to know that. And then all the rest of the cells are 45%. This is not correct. The red blood cells make up about 43.5% probably of that remaining 45%. But 45% is called formed elements, or the cells. And the buffy coat are your white blood cells and platelets. But I want you to know that this breaks down this way: 55% plasma, 45% cells. That's way too busy. You don't have to know all this, but we are going to define these different blood cells here in this chapter. There's one common ancestor called a stem cell. It's called a hemocytoblast. That might be something good to know for the test. It gives rise to all the other cells. They will differentiate into whatever cell they need to be. And there's a chart, also very busy, of the stem cell becoming every cell we would want it to be. All right, the first one we're going to talk about, and some of this should be a little bit of a review from chapter 5 last time, the red blood cell, or erythrocyte. Remember that term? You should know both of those. Some of the details on this: oxygen transport is its function. They only live 120 days because they don't have nuclei or mitochondria, so they have to constantly be produced in the bone marrow, and we'll talk a little bit about how that happens as we go on here. Also want you to know that, just as an all-encompassing number, let's just say 4.5 to 6 million per cubic millimeter. Now, I don't know how big a cubic millimeter is, but it's not that big, so that's a ton of cells. And you should remember looking at those last semester on your slides and seeing all those little dots. We used that for the microscope. Lab we did. Okay, when you are filtering your blood, your kidney actually will detect through chemoreceptors how much oxygen is in the blood. And I'm finding myself lecturing here, but I'm trying to do a little lecture with the lab, so hopefully this thing will even upload. But the kidney is primarily responsible for detecting low oxygen in the blood, and it is going to produce something called erythropoietin right here above my hand, and that erythropoietin will stimulate the production of red blood cells in the bone marrow. The kidney does about 75% of this function, so let's focus on it rather than the liver, but know that for your exam. Skip it. Okay, on the types of anemia, I want you to know the first 5 types, and I'm going to give you something on this chart. I'm going to do a few more tables on this exam, which I usually don't do. I always do, but I usually don't, do that for you guys, so if that makes any sense. But I do these semester in, semester out, but we're normally not table people when we review. We don't do those, but there's some good information on these in these particular chapters. Aplastic anemia, these could be matching on your test. I can't remember exactly, but aplastic anemia Just remember, this is can be caused by radiation or toxic chemicals. Sometimes we cause this because we want to maybe do a bone marrow transplant, so they will actually kill people's unhealthy blood cells, and this is how they do it. Hemolytic anemia, if you remember hemolysis from last semester, if you get a blood cell in a hypotonic solution, it'll swell and possibly burst. So no, that iron deficient is exactly what it says. If you don't have enough iron, iron is what attracts the oxygen basically to transport in your blood. So again, some of these are lack of cells, some of them are lack of something on the cell, which will make you anemic and cause you problems. Pernicious anemia, this is where you don't have enough intrinsic factor produced by the stomach, so you can't absorb vitamin B12. And then the last one, sickle cell, comes from a defective gene, and this is almost exclusively found in African American people. So just know the difference in those 5 there. Okay, I'm going to try to streamline this a little bit. Types of white blood cells. The first one is the neutrophil, and I want you to think of it as being like a first responder to an infection, primarily to a bacterial infection. These are the most plentiful of the white blood cells. They're phagocytes, and again, these are the first responders. That's what I want you to know, that they respond first in an insult. Eosinophils, think of allergies, allergic reactions. We hear this a lot of times. These will end up in the lungs sometimes when somebody gets inhales something that they're highly allergic to. The eosinophils will consolidate the lungs, so think allergies with those. Basophils, we talked about these last semester. I didn't test you on them, but I talked about something called the mast cell, M-A-S-T. These will become a mast cell, and mast cells reside along blood vessels, and they release heparin and histamine when there is damage. You should remember that from last semester. Probably only one of you is nodding your head right now. But that causes inflammation. That's the bottom line, inflammation. Associate basophils with mast cells and inflammation. Okay, monocytes. Look at how big this cell is. It's about 6 times the size of red blood cell. These will become a macrophage. Macro means large, phage, remember, means cell eating, so it's a large eater. So it's a phagocyte, but I just want you to associate the monocyte as becoming a macrophage. Lymphocytes, there are 2 types, and we're going to hear this in chapter 16. We'll hear this about 3 times during this review. T cells, if you hear T cell or T lymphocyte, think thymus gland. That's where they go to mature, that's where they live, and think cell-mediated immunity. Cell-mediated immunity means these go out and fight hand-to-hand combat. B cells, think spleen, they go to the spleen. They differentiate into something called a plasma cell, and it'll send those out to create antibodies in the body. And we're going to talk about some antibodies in chapter 16. So we'll hear this 2 more times before we're done. Skip over to these. You'll probably possibly learn in your program, maybe not. You're not going to be diagnosing if you're a nurse, but you probably will have to learn this at some point. All right, platelets. Just simple enough, blood clotting. They're called thrombocytes. A thrombus is a blood clot. So just think blood clotting with the platelets. Again, plasma, 55% of the blood. It's primarily water. I'm skipping through some of this because I'm just going to I can't spend this much time. This will take 2 or 3 hours to upload easily. So I'm trying to get it to you. So let's go on over to hemostasis. I want you to know the stages of hemostasis. This is blood stoppage as when you are clotting the blood. This is what happens. The blood vessel goes into spasm, the smooth muscle, and usually that's a result of being exposed to collagen, I believe. Then the platelets get sticky, or the thrombocytes, they get sticky and form a plug, and then the blood coagulates or stops. There's some explanations of those. If you want to read through them, there's a chart about it. One of my favorite pictures in the book. This is showing, the blood clotting is way more involved than what we're giving you here. In fact, they call it the blood clotting cascade. You should look it up. There's about I don't know how many different factors or probably enzymatic reactions that have to take place for your blood to clot. It's very, very involved, very complicated. But this is like showing the red blood cells being caught by a net, which is really cool. All right, fate of blood clots. You might know these terms. I'm not saying they'll be on the test, but a thrombus is a blood clot. Some of you may have heard of the condition deep vein thrombosis, where people get blood clots in their legs, in their veins. An embolus is a blood clot on the move. And you guys will learn, probably have already learned, some of you, that when you're doing phlebotomy, you can actually introduce an air embolus if you don't do that right. If you're taking blood and you push air into the system, you can cause an embolus and kill someone. So, all right, let's go on. I want to mention something here, just to go back to, I know this is sort of a review, but I can't help but lecture a little bit here too, because you guys aren't getting that. But this is the inside of a blood vessel. What we call the lumen is the opening. This shows some plaquing. Now, keep in mind this is a dead blood vessel, so it looks a little jagged along the edge. But I want to read something verbatim that I told you about the cholesterol myth, the lie that goes along with it. And I never do this, but the smooth lining of blood vessels discourages the accumulation of platelets and clotting factors. And I think I told you this last semester. This is why people get cholesterol accumulation, because their blood vessels are unhealthy. And they get rough. The collagen gets unhealthy. The connective tissue, which we found in the inner layer, if you remember chapter 15, the tunica intima and the tunica externa, or adventitia, both have collagen in them. And the best maintainer of collagen is vitamin C. So get your vitamin C. My wife and I have been getting our vitamin C because she actually is drinking grapefruit juice with me every day. And I never thought I would see the day because it's very sour, but we love it now. All right, let's go on here. We need to get through this. The blood typing, go back and look at the other video I gave you. The book is so confusing on this. This is why I did the video. Sorry, I went backwards there. I do want you to know the term antigen. I went over that in the video for your test. But here is how they describe the blood typing, the antigens, antibodies. It's very confusing. And I keep going backwards. I apologize. This laptop has a mind of its own. Here's showing you a normal blood smear. Here's showing you what happens if you put the wrong blood in someone. It agglutinates. But again, go back and there probably will be one or two questions on blood typing on this particular lecture exam. You've already been tested on that on the last lab exam. So there you go. But if you know this chart, which I drew out for you on that little lecture on my little whiteboard over in the garage, we're actually doing this on the TV screen, you will know what you need to know about blood typing. All right, the RH factor, again, if I didn't do this on, I don't think I got a chance to tell you guys this, so on your lab test, I'll probably just give you this question, but the RH factor, which we said is just another antigen. This is what gives you the plus or minus in blood typing. Again, go back and look at that video. This is mainly significant in women when they're pregnant. And this little pictorial view shows you what is important here. If mom is RH negative and her baby is RH positive, she will form an antibody against it, that baby, while she's carrying it. And generally it doesn't really affect the first child. It will affect the second child if the second child is also RH positive. And obviously they get that from dad. So keep that in mind. The second pregnancy is usually the one, but this is why they give people shots of something called Rogam to alleviate that. And I think that's the end of that chapter. So let's go on to the next. As you know, I'm spending much more time on the review than I normally do, but we got a little different situation. So let's get right into chapter 16. I thought I had this set up here. 16 is the lymphatic system. We're going to hear some repetition from what we heard in chapter 14. And I'm probably going to have to streamline this. I'm spending too much time on this. And honestly, I did a 39-minute video for the skeletal system for 137, and it took over 2 hours to upload, and we had to do it twice. So just crazy. All right. This tells you what the functions of the lymphatic system is. And right through here. Know those functions of the lymphatic system. I'm going to streamline this a little more than I did in chapter 14, unless there's a point I need to make here, because you guys will just have to kind of learn these. Again, we've talked about lymphatic vessels, we talked about lacteals that we primarily found in the small intestine, Peyer's patches, which are more tonsillar accumulations, but the lymph capillaries are the lacteals, we call them. Lymph vessels most resemble veins. They are almost like a second venous system. They have valves, so they most resemble veins. You don't have to know all the regional ducts or the regional trunks in the ducts, but we will give you a little flow through there. These are the pictures you had for your lab. So let's go on. These are cadaver pictures you don't need. All right, I do want you to know the general flow through the lymphatic system. So we start with a lymph capillary, then we travel on an afferent lymphatic vessel. You may remember afferent from the sensory division of the nervous system last semester. It means it's going to something. In the case of sensory, it was going to the brain. Here, this is going to a lymph node. Then we have an efferent vessel going away from it. It's picked up in one of these regional trunks, and then it goes through one of two collecting ducts, either the thoracic duct or the right lymphatic duct, and then empties into either the right or left subclavian vein. If it's the right lymphatic duct, it empties into the right subclavian vein. If it's the thoracic duct, into the left subclavian vein. So just kind of know that basic flow for the test. Again, more cadaver pictures. This should say tissue fluid and lymph. This is a mistake, I'm sure. And all this says is in order to have lymph, you have to form tissue fluid. And I can't draw it on this board. If I had the whiteboard, I could, but we just can't do both at once. But if you remember the little diagram I drew last semester when I was reviewing the cardiovascular system, I drew a little capillary network, and we said that on the arterial side, plasma is still inside the vessel, so the pressure is greater in the vessel than it is outside the vessel. It forces plasma out. But when it does, when it forces that plasma out, that is what is known as tissue fluid. And then I also said that the immediate drop in pressure sucks it right back into the venous system, but all of it cannot get sucked in, so the lymphatic system has to suck it back in. You should remember that. Once what is taken back in by the lymphatic system is now called lymph, but it's plasma. Tissue fluid is plasma, lymph is plasma. So you have to have tissue fluid formation before you can have lymph formation, is all this is saying. All right, let's go on. In fact, it says right here, which always cracks me up, much the same consistency as plasma. It's because it is plasma. So it's a little different stuff in it, though. All right, let's go on. The function of lymph. You should know the function of lymph, which is kind of stupid in a way because it says it collects excess interstitial fluids. It is the excess interstitial fluid. It is the tissue fluid that becomes lymph. So it's collecting itself, apparently. It's delivering itself to the bloodstream, and it delivers foreign particles to the lymph nodes. So just know those as functions of the lymph. This should look familiar to you. Action of skeletal muscles, respiratory movement, valves, and smooth muscle. This is the exact same four. These are four factors that help lymph go back to the bloodstream. Same four factors we gave you for venous return of blood last semester. You should know those. Let's go on. I'm going to just kind of hit. There's a lymph node. Looks like something I blew out of my nose this morning. Not much form or function to it. And again, lymph nodes, this is where we actually are going to fight certain things. This is where you get the immune surveillance from the lymphatic system. Again, we have an afferent vessel bringing it to, efferent going away. You can see in the inner portion of the medulla, we have macrophages, T cells, we have macrophages and B cells out in the capsule. Here's the locations. What I want to get to are the functions. I just passed them. Know the functions of the lymph node. They filter harmful particles, they act with immune surveillance, and they are sites of lymphocyte production, which is news to me, but the book says that they are. All right, thymus and spleen. I said we would hear something 3 times, and here's where you're going to hear it. And I'm going to say it right here very succinct so I can skip a bunch of slides. If you think thymus, if you hear thymus, think T cell, T lymphocyte, cell-mediated immunity. The T cells going out and fighting hand-to-hand combat. When you hear spleen, think B cell, think plasma cell, which is formed from the B cell, and think antibody production, which is called antibody-mediated immunity. So that's the second time we've heard this. We're going to hear it 3 times. So I'm going to skip through some of these. That's the primary thing that this is saying, or that I want you to get out of that. Okay, and then we switch gears a little bit. We're going to talk about immunity at the end of this chapter, and I'm going to go through this very quickly. Now, we have 2 types: innate defenses, which are inborn, you're born with them, and adaptive defenses, which we just talked about, actually. So, here's a table. I want you to know this list as being all non-specific or innate defenses. It's in your PowerPoints, but know it as a list. I'd probably pick E on that question when it comes up. Probably going to be all of the above. Now, I can go through each one of those. I'll let you do that. I usually go through a little discussion of each one of these, especially the last one, fever. And I'm just going to say this real quick. A fever is your body's response to a pathogen. That's why we shouldn't just arbitrarily lower a fever. And this is very hard to do when in reality. I remember, I'll tell the story real quick, and it's going to extend our time here, but our oldest son, Jared, I lived very close to my office at that time, and I would walk home for lunch, and my wife and I would play with Jared. And I walked home one day, and before I left, I don't remember exact timing, but she said, "I think Jared has a fever. Do you want me to give him Tylenol?" And I said, "No." Not thinking that his fever could go up really significantly. So when I get home, he's sitting on the couch like a Raggedy Ann doll, and I said, "Let's get him in the bathtub." But what we were trying to do is let his immune system flex. Again, fever destroys the pathogen. It's very hard when you see your child in that condition. Okay, specific immunity, one more time. Thymus, T cells, T lymphocytes, cell-mediated immunity. B cells, spleen, plasma cells, they become plasma cells, antibody-mediated immunity. That's what I want you to know. So skip through all this stuff till the end. That'll narrow it down for you, as I like to do, in the review. But there's a couple tables here I want you to look at. Here's one of them. When we produce these antibodies, here are the different types, the different names. And I want you to know what I'm going to tell you about them, not what's on the chart. IgG is the most plentiful antibody. This is called immunoglobulin G. I don't have a lot of time to talk about it because we'll never get this uploaded. IgA is found in tears and saliva. IgM is the first antibody to be secreted when something invades. IgD, we'll go with what's on the chart here. It activates B cells, and IgE has to do with inflammation and allergic reactions. So I want you to know those. Those could be, I probably have those in a matching on your test. Then there's another one here. This one, very important. We're talking about this right now, basically, which apparently this is a virus you do not want to encounter, but naturally acquired active immunity is usually your best defense. In other words, you're exposed to that live pathogen. Artificially acquired active immunity is when they give you a vaccine that has a dead or almost dead pathogen in it, which is like being exposed to it, but it's artificial. They put it in you. This is natural. Artificially acquired passive immunity is like an allergy shot. Think of it that way. And then naturally acquired passive immunity, this is natural. This is mom. This is what crosses the placenta to the baby, which gives the baby, the fetus, and then the newborn baby mom's antibodies. Also, when she nurses them, they tell you, even if you're not going to nurse your baby, you should do it for 2 or 3 days so they get the colostrum in the breast milk, which is full of antibodies. So know the difference in those, what I told you about, and that'll be matching as well. The rest of this, we're not talking about any, just skip it. We don't have time. So let's go on into chapter 19. I know I'm talking very quickly, but hopefully you'll be able to, this will help you. You can listen to this and then kind of hone in on those particular subjects. Okay, chapter 19 is the respiratory. This has a little bit more physiology than the rest of them, but I'll try to be brief. Some of this you may have to teach yourself a little bit. All right. Usually when I do this chapter, I start right here and talk about 3 of these terms. Ventilation is just simply putting air in the lungs. There's no exchange of gas, no chemical exchange. External respiration is when we exchange gas between the alveoli in the lungs and the bloodstream, the blood vessels that are going through that. Internal respiration, that's the third one. Don't worry about these others for right now. We've talked about cellular respiration, and we do not want to go back there, I don't think. But internal respiration is when you exchange the gas from the bloodstream with the tissues or cells. So know the difference in those 3. Why we breathe, this just says because we're going to undergo cellular respiration. Now, a lot of this will be more lab stuff. You've already been tested on this in the lab, so there's a lot of anatomy at the beginning of this chapter. I'm going to skip all through it. All anatomy that you've been tested on. So let's skip through all these pictures. All these pictures. Okay. I might ask you something from last semester. What type of epithelium is found in the respiratory tract? That should be reviewed. It's pseudostratified columnar epithelium. Here's a picture of it. I might also ask you what is found in the alveolar sacs, and that is simple squamous epithelium. So know the difference in those 2. This should be paranasal sinuses. This is a good review. You should already know what bones we have a sinus in, but I may ask you that. But I also want you to know the function of the sinuses. This may be later in the chapter, but I'm going to do it right here. They lighten the weight of the skull. In other words, they make it less heavy. And then they help to resonate sound. If I have my sinuses are consolidated, I sound like I'm talking through my nose. So that is a function of the sinuses, so your sound resonates. All right, so I'm going to skip forward here, skip forward. This is all anatomy, still anatomy. You've been tested on that already. Tested. Let me go back here 1 minute. This is a horrible picture. It's very small down here, but this shows you the vocal folds, the true vocal cords and the false vocal cords. The false vocal cords in this bottom picture, and it may be bigger in your text, you can see just a shiny, almost like the flash has kind of reflected off of it, and it's just like a roll of skin. But then you see this V shape, and those are actually your true vocal folds, and those are actually elastic cartilage. I was flipping through the channels one time, and I saw the channel Nova, which is for nerds, which I am, and Steven Tyler. And Steven Tyler, if you know who he is, lead singer of Aerosmith, I thought, what is he doing on Nova? Well, they were putting a fiber optic camera down his throat and watching his vocal cords as he screamed one of his classic song lyrics, and it was amazing. I'm surprised he wasn't hoarse every time he sang. But just real quickly, this may or may not be on the test, but the loudness of a sound is determined by how much air is flowing over the vocal folds. This is why you need to breathe in very deeply if you're going to talk loudly. Another thing, the pitch of the sound is determined by the tautness of the vocal folds. And in young men, part of puberty is when their vocal folds get a little bit looser and a little bit wider. Females are skinnier and tighter generally. This is why when you hear these singers like, although who's the little country singer that's about 4 foot tall, great singer, Hunter Hayes, and he sounds like he's singing like a little girl. It's because I don't think he's ever really gone through the second stage of puberty. Just a theory I have. So let's go on here. Again, anatomy. I do want to point out this is the hyoid bone, and look at some of the tendons and ligaments. They're not showing the ones coming off the top, but very important for voice production, swallowing, etc. Let's go on. Way too much stuff there, and it's all anatomy. All anatomy. You've been tested on this for the most part. We'll get to the physiology eventually. Still anatomy. We will talk about this in a moment. This is the alveoli in cross section. So there's an alveolar sac right there. I'll talk about that later in this chapter. Something significant about that. Good grief, there's a lot of anatomy. All right, we're starting to get into physiology. If you can play these films, play them after you've gone through the chapter, because it's a little much to do it here, and there's something very hard in this chapter in the physiology. Again, anatomy, so many pictures that you don't need for this particular test. All right, the pleural membranes, I want to review this real quick. Visceral pleura, remember, covers the lung directly. Parietal pleura lines the pleural cavity, each pleural cavity, or each thoracic cavity. Remember, the mediastinum splits that into two. So visceral and parietal pleura, review that. That's from last semester, but you may see it on this test. Picture doesn't do them justice. All right, breathing mechanism. We're finally getting to the physiology here. Okay, this is a great analogy on inspiration. It shows a syringe with it coming out and then going back in. If you think of the little stopper in here, the little plunger as being the diaphragm, this is what happens in inspiration. The diaphragm descends, and let me go over just a little bit of physiology. You can look it up, but it's not in your notes, but it's Boyle's law, I believe. The name is not important, but it says that pressure and volume are inversely related. What does that mean? That means as volume increases, pressure decreases. And the best analogy I can use, if you use propane, or if you've ever seen a propane tank, you can get propane tanks as small as, for your grill, 20 pound, you can get them 100 pound, you can get them 100 gallon, you can get them 330 gallon, or like my brother-in-law and sister, who are rich, they have a 1,000 gallon tank because it heats their indoor pool. But if you put the same 10 molecules of gas in a grill tank versus that 1,000 gallon tank, the grill tank is going to be under higher pressure because it's closed in. If you put it in the 1,000 gallon, it's going to be under less pressure. So that's a good analogy. Same thing happens in the lung. And we're assuming at sea level, atmospheric pressure, just like blood pressure, is measured in millimeters of mercury. So at sea level, atmospheric pressure is 760 millimeters of mercury. So if I breathe in, my diaphragm contracts, my external intercostals contract. I said that slowly for a reason. The diaphragm descends, the ribs pull out, the volume of your thoracic cavity increases, the pressure decreases below 760, so you inspire. And again, I'm lecturing here, but that should help you. The air flows in passively once you breathe in. It's not passive breathing in, but once you increase the volume, the air should just flow in. And it says that. Read through here. It says it gets down to there. It shows you that. Again, the diaphragm and the external intercostals and the diaphragm, these are the ones I'm focusing on. There are more muscles involved, but those are the two primary when you're breathing in. Okay, this might sound a little bit, there's another good table that shows you about inspiration. There's two types of expiration, and hopefully you can distinguish between these. After I breathe in, if you breathe in and try to hold your breath, your lungs will start to almost hurt because they're stretched and there's compliance in the lungs. So when you expire, just a normal, what we call a tidal inspiration, expiration is passive. It's from the recoil of the lung tissue and the muscles. So a normal tidal expiration is passive. If I force expiration, and the example I'm going to give you is blowing up a balloon, right, then I am having to employ muscles. It's no longer passive, it's active. So this slide is talking about, this slide is talking about a tidal passive expiration. This slide is telling you you need to employ the internal intercostals to force air out. So that's when you're forcing expiration. So know the difference in those. All right, volumes and capacities. We used to do a lab on this. I'm going to talk about two of these only. Actually, maybe just one of them. But I want you to know what residual volume, which I may use the abbreviation RV as residual volume. It's not recreational vehicle. That is the amount of air that stays in the lung after I've blown up the biggest balloon I can. There's still air that stays in the lung. If it didn't, your lungs would collapse. And that volume is about 1,200 milliliters. This is what is affected in smoking. People destroy the cilia on the pseudostratified columnar epithelium, and they widen out their bronchioles. So there's more air can get in the lung, not less. People think people with emphysema can't get air in the lung. They can. They can't get it out because their lungs are no longer compliant. And that's residual volume will increase in that. Other than that, you can read through these. There's a chart that this explains it better. But I want you to primarily focus on residual volume and tidal volume. Tidal volume is this. Normal breathing in, normal breathing out. Hope you like the sound effects. In a normal tidal volume, and this is what this is talking about, you can read this slide. Not all that air gets to the lung. It's kind of like if I turn my water hose on and have a sprinkler can at the end of it. I fill up the sprinkler can and then shut off my little nozzle on the end of the hose. There's still water all the way back to the valve, isn't there? Same way when you breathe in. When you breathe in, only so much air actually reaches the alveoli for that external respiration. And that volume is 70%, or the amount is 70%, and it's 70% of 500 milliliters, which is the tidal volume. I know I'm going quick here, but your tidal volume average is 500 mils, so 70% of that, 350 mils actually reaches the lung. The other 150 mils is in what we call dead air space. You'll just blow it back out. All right, that was a lot just to say that little bit. Non-respiratory air movements, I would like you to know this table as non-respiratory air movements. Might be another all of the above question, you never know. Let's go on here. One interesting thing about breathing is that it is conscious and unconscious. When you go to sleep, you don't have to wake up every 3 seconds and tell yourself to breathe. So that is unconscious, but I can breathe consciously as well. I can control that. So it's voluntary and involuntary. All right, how do we control some of the rate of breathing? This is where it gets a little more physiology, and hopefully you'll understand this. Let's wait on this. I'm going to go on up here. And we're talking about the medulla, the part of the brain with the primary respiratory center, which is also a review from last semester. Remember that. The medulla had cardiac center, vasomotor center, respiratory center. So we're going to talk about the effect on the medulla, even though the pons in the brain also affects your rate and rhythm of breathing. Think about the medulla for the test, period, because it's the primary respiratory center. All right, I'm going to try to describe this. Partial pressure. When you hear partial pressure, this is going to confuse you. Just think concentration. It's the same thing we talked about concentration last semester. So if you have high partial pressure of oxygen, it means you have a lot of oxygen, a lot of concentration. If you have low partial pressure, you have low concentration of oxygen. Very simple, common sense. Look at the lab that was in your last lab exam where I did the holding your breath. If you understand the physiology behind that, you will understand this. As oxygen goes up, your medulla does not get stimulated because we're talking about oxygen level in the blood. So if I breathe a lot, it's going to tell the medulla to make you stop breathing because you have plenty of oxygen in your blood. If carbon dioxide goes up, it's going to make you breathe. Carbon dioxide is acid, so it makes you breathe. Emotional state. Most people, have you ever seen someone cry? They're going, that's increasing the rate of breathing normally. Level of physical activity will increase the rate of breathing. So most of these are common sense. Read through them, but they're common sense. pH. Again, carbon dioxide is acid. The reason it's acid is it immediately forms carbonic acid in the blood. And we buffer that by pulling off a hydrogen and forming bicarbonate. There's an enzyme called carbonic anhydrase. This will not be on the test. But that hydrogen ion, remember, hydrogen ion means what? Acid. Remember pH. The more hydrogen ion concentration you have, the more acidic. So carbon dioxide equals acid. So if there's a lot of carbon dioxide, there's a lot of acidity, the pH goes down, that will stimulate you to breathe. If there's a lot of oxygen, that's more alkali, pH goes up, that will cause you not to breathe. So just think of those. Pretty simple if you think of them in common sense terms. I've got to get done with this, so let's get this really quick. Okay, alveoli. Two types of cells here I want you to concentrate on. Type 1 alveolar cell is that simple squamous epithelium in the wall of it. We talked about that last semester. I just mentioned it earlier. That is a type 1 cell. Type 2 cell secretes surfactant. Surfactant causes a decrease in surface tension in the alveoli. It's like rubbing two balloons together. If you rub them together, what are they going to do? They're going to stick. Surfactant is like a detergent. It keeps these from sticking together. These are destroyed, these type 2 are destroyed in smoking as well. So that, with the increase in the volume there, the lungs cannot deflate. They can inflate, but they can't deflate. So just know those two types for the test. That explains it. Great picture there. Here's an alveolar space. Here's a capillary. There's the blood cells. And you're going to exchange oxygen into here, carbon dioxide into there. Pretty cool. Something happened to my slideshow here. Oh, great. Sorry, I'm gonna have to start from the beginning here. Okay, there we got it. Hopefully. Okay, we're back up. Okay, all this is saying is exactly what I said earlier. This is what I drew for you last semester about the cardiovascular and the lymphatic system. As air is coming in toward the lung, here's the alveolar space, here's the capillary. Actually, this is a little different, so just let me explain this. This is a branch of the pulmonary trunk of the heart. We went through that flow. Pulmonary trunk, remember, splits into right and left pulmonary arteries, goes to the lungs to take that blood to be oxygenated. So it is deoxygenated here. Look at the concentration. This is PCO2, PO2, partial pressure. Think concentration. The concentration of carbon dioxide is 45 millimeters of mercury. Concentration of oxygen is 40. In the lung, oxygen is 104. Carbon dioxide is 40. If you remember simple diffusion and concentration, a substance will diffuse down the concentration gradient. So in other words, this is going to go, carbon dioxide is going to go where it's greater to where it's less. So it's going to come out of the blood into the alveolar sac. Oxygen is going to come out of the alveolar into the blood until we reach equilibrium. So again, this is external respiration. Then that's going to flow out and go to the tissues. Oxygen is going to go into the tissue because it's low. Carbon dioxide is going to come out of the tissue because it's high. That's internal respiration. So just realize there's gradients there. And I've got to get through this or we'll never get it uploaded. Let's see here. Just want to mention, oxygen is primarily transported as oxyhemoglobin in the blood. Oxyhemoglobin is how oxygen is, it's bound to hemoglobin. Wait a minute, I want to make one point here. You know, we talk about deoxygenated blood, which means not oxygenated, but look right here. 75% of oxygen remains bound to hemoglobin in venous blood, which means we've already given up all the oxygen to the cells and we still have 75% bound to hemoglobin. Why? Because it keeps us from dying. It's a safety mechanism. So when we say deoxygenated, it just means less oxygenated. All right, let's go on here. Get through these. These are useless curves. Carbon dioxide is transported primarily as bicarbonate ion. I want you to know that. I'm just cutting to the chase here. Here's that whole sequence of events where we have carbon dioxide bonding with water to form carbonic acid. We have a carbonic anhydrase enzyme that splits it into bicarbonate and hydrogen ion equals acid. Sorry to be so quick. This is probably coming to be crazy. Great film to watch. Watch that on your PowerPoint if you have it. Probably don't. And that's the end. I'm going to jump back in here. That's the end of the review. I'm going to do that for your next lecture test. Hey, we don't have a lot left to go. We have one test after this, which is over 20 and 13, be really short. We have one more lab exam to go. And here's some exciting news. Those are not going to be full exams. If you noticed, your last lab exam was only 47 questions. Your next lecture exam over 2 chapters will be 45 questions, and the lab will also be shorter because you have the take home. Some of you have already sent that to me. So I'm going to cut it off here so we can actually get this uploaded. If you have any questions, email me. Bye.